Good evening. My name is Gaurav Ghosh. I'm an adult gastroenterologist at Weill Cornell's Digest program, which stands for Dedicated Integrated Gastroesophageal Treatment. And I am an esophageal specialist, including for this condition that we're going to talk about tonight on the webinar. It is for eosinophilic esophagitis, also known as EOE. And we have a really great panel for you today. Some true experts of this condition who are all going to bring their different perspectives to the table. So I'm going to start by introducing them. First, we have Dr. Carolyn Newberry. Dr. Newberry is an adult gastroenterologist like myself. She is a director of GI nutrition here at Cornell. Next, we have Dr. Eliza Solomon, who is a pediatric gastroenterologist who also treats EOE, and she is the director of the Eosinophilic GI Disorders program. Next, we have Alex Rosenstock, one of our excellent dietitians, and she's the lead GI dietitian. And we're just really lucky to have all of these people here today to talk with you about EOE. So, with that in mind, a little housekeeping. We'll start with a quick disclaimer. You're going to hear a lot of general information about EOE today. You're going to hear a lot about our opinions. But if you would like more specific information, more personalized information, please feel free to reach out to us, and we'd be very happy to see you in clinic. So what are we going to be talking about tonight? We are going to be talking about what is eosinophilic esophagitis, how common is it, what are the symptoms, how do we evaluate it, and what are the treatment options. And thank you for all of you who have already sent in questions. I'm going to be trying to weave in other questions and answers that you've already sent in, but if during the webinar you have additional questions, please feel free to use the Q&A box to send in your questions. We have Dr. Ashok, one of the other adult gastroenterologists, who will be trying to answer those in real time. So let's get to our patient. So we have a 22-year-old man who has had 3 years of reflux. At least 3 times per week when eating, he feels food getting stuck in his chest and he feels it needs to come up, but he drinks water to make it go down. He saw his primary care doctor a couple of years ago for this and was told it was likely reflux. So as a result, he takes over-the-counter pantoprazole as needed. Over the last year, he has started to notice food is sticking in his chest more frequently. And he has occasional heartburn, but no nausea or vomiting. Overall, he's a pretty healthy guy, just has frequent eczema. So this is a pretty frequent patient or type of patient that we see in our clinic. But Dr. Solomon, tell us a little bit about what jumps out to you about this patient.
Sure, thank you. So obviously the length of time that he's had his complaints, the fact that they're happening pretty frequently during a week, so 3 times a week. In addition, it's getting worse, and this is despite trying to use something over the counter to really help the complaint. So it's persistent despite the medication. Also, these complaints of these swallowing issues, so having trouble needing to drink to help things go down. This is something, he's a young guy, so such frequent reflux always raises a question of what's actually going on. And then the history of eczema is also something that raises suspicion for this condition, because people who are have eczema or asthma or things like that in that nature tend to have be associated with eosinophilic esophagitis more commonly.
Great. I think that what you said about what is actually going on is a great way of putting this. Anytime I hear about someone saying they have reflux, I really want to understand what is actually going on. Some people might use the word for reflux to describe heartburn, but clearly this is not what's going on with this patient. It's something else. So Moving on, we hear a little bit more about his symptoms. He's cut out all alcohol, coffee, citrus foods, and pasta sauce, but this didn't really help his symptoms. He usually drinks extra water with his meals to help food go down. He cuts his food into small pieces. He chews the food until it's mush and notices he's always the last to finish his meals. To avoid this issue, he has started limiting tough foods like steak or grilled chicken and stopped taking his multivitamin, which he was occasionally choking on. So he goes to his gastroenterologist for evaluation, who schedules him for an endoscopy, given this worsening of his symptoms. Again, Dr. Solomon, I'm going to pick on you here. Anything new that we're learning here?
Yeah, so the first thing he did was really eliminate things that you think of classic reflux triggers, and that really didn't help. But the rest of it really speaks to what we call adaptive feeding behavior. So, someone who is changing the way they normally eat to eliminate or minimize their clinical or their symptoms. So, what ends up happening is he's drinking water to help things go down because they're not going down as smoothly as he would expect. He's adapted and cutting his food into smaller and smaller pieces. He's eating slower to maybe prevent these episodes of food getting stuck. He's limited the tougher things. We think steak, big chunks of chicken, bread, like hard bread, like bagels, things that are really tougher to go down or may cause more symptoms. And these are things, and another question that I tend to ask also is, how are you with swallowing pills? So some of these people who used to be able to swallow pills now feel even pills getting stuck or more difficult to go down. So it's crucial that the physician who's treating them really asks questions, pointed questions about any adaptive feeding behaviors that have developed, because it should really raise that red flag that you were mentioning.
Yeah, that's so right. You need to be really delving a little bit deeper sometimes with these patients. Trouble swallowing isn't always this big dramatic choking type event. It can be a lot of these more subtle signs like we're seeing here with this patient. So we're going to move on. This patient went for an endoscopy after seeing his gastroenterologist. Dr. Newberry, what are we seeing here?
Thank you, Dr. Ghosh. Yeah, so on the screen here, you can see two endoscopic pictures of the esophagus. So the area where we see these problems. And later on in the presentation, we'll be able to show you actually pictures of a normal esophagus so you can compare what this looks like. But I don't know if you noticed like the rippling in the first picture, it almost looks like ocean waves. And that really is not something we see in a healthy esophagus. It's a texture change. It's that difference in the rings that you're seeing. And on the right side of the picture, you're actually seeing these vertical lines going down the esophagus. And we have some yellow arrows there that are depicting where those lines are. And those are something called furrows. And additionally, those can indicate this type of inflammation we see in EOE.
Great, thank you. Yeah, we'll see some normal esophagus pictures later, and then you'll have a better way to compare what's normal and what's not normal. So we're kind of leading toward this idea that this patient might have eosinophilic esophagitis or EOE. So what exactly is that condition? Dr. Solomon, again, talk to us about it.
Sure. We think about EOE as a chronic, more immune allergic condition. So what ends up happening is the inflammation deposits in the wall of the esophagus. The inflammation is generated by eosinophils. Eosinophils are white blood cells, a type of white blood cells that are typically found in allergic conditions, and they really deposit inside the wall of the esophagus. So unfortunately, there is no blood test or any other test that can detect these buildup in the esophagus. So really, we have to end up doing endoscopy and looking under the microscope to detect the number of eosinophils that are present there. And we know that it is typically found when there are more than 15 eosinophils as we look under an area in the microscope. The problem with that is that not only does the inflammation lay down, but underneath the surface, even in a slightly deeper level, there can be cells that in response to the inflammation, try to heal and repair, but end up causing scar tissue. And a lot of this combination of the inflammation and the scar tissue actually influences the way that the esophagus works. So it's an esophageal dysfunction because normally the esophagus would contract. It contracts from the top to the bottom. It helps when we swallow, moves the food down the esophagus. But when it's not doing that, that impairs how it's contracting. So it may not allow food to clear. It may not allow acid to clear. And that actually is what ultimately causes those problems with swallowing.
That's a really great and clear explanation of what EOE is. Just to kind of, again, weave in a question that we received earlier. There was a question about what is the relationship between GERD, gastroesophageal reflux disease, and EOE. GERD is an inflammatory condition where acid is coming up from the stomach into the esophagus. And so if you see inflammation or eosinophils in the esophagus from GERD, it's more likely at the bottom of the esophagus. We can see here in this picture on the right that the bottom of the esophagus is close to the stomach. EOE, that eosinophil buildup can be really all throughout the esophagus, impacting the function of it. So let's keep moving. So what exactly is causing EOE? Alex, can you talk to us a little bit about that?
Sure. Eosinophilic esophagitis is basically your immune system's response to some type of allergen or allergens. And we commonly think of these as food, and they certainly can be food allergens, but they can also be environmental allergens that the body produces an immune response to.
Yeah, I think that a lot of people, and frankly, the most common things that are going past your esophagus are food, but anything that you are exposed to and wherever you are, in your apartment, in the city, can make its way instead of to your lungs, down into your esophagus and generate that inflammation. I'm going to give everyone a little bit of a break, and I'm going to talk a little bit about how common is EOE. In the United States, it's approximately 1 in 700 people are going to have EOE, but because of awareness increasing in this disease, we are noticing that there are more people being diagnosed with it on a yearly basis. And in general, people are just becoming more allergic. So we're just seeing an increase in all allergic diseases. We can see also here at the bottom, it says that almost 10,000 emergency room visits happen every year in the United States. And it's usually because food is getting stuck, and the only way it can be removed is by going to the emergency room and removing it with an endoscopy. On the right here, we're seeing a little bit about the age breakdown and the gender breakdown of EOE. You can see the black bars are higher in general than the gray bars, suggesting that this is more often affecting men than women, but all of us have plenty of patients with women who have this condition. The disease tends to skew a little bit younger. You can see that the peak is kind of there in the 30s. But again, well, I was going to say all of us have patients that are older than that, but maybe not Dr. Solomon. But we see plenty of people of all age groups, very young and quite a bit older, who are affected by EOE. So, what are the symptoms that make us think that someone has EOE? Dr. Solomon, you told us a little bit about it related to our patient, but maybe more specific to a general EOE patient.
Sure. So we talked a lot about this idea of swallowing problems or food getting stuck, but it really depends on the age of the patient. So as a pediatric gastroenterologist, I do see patients who complain of this, but it's usually more the adolescent and young adult population. In infants or children, sometimes it's feeding difficulties, feeding refusal, not wanting to eat, could be gagging, choking, or vomiting. Or maybe they're just refusing to eat, and that's led them to actually have poor waking or failure to thrive, as we call it. In a little bit older school-age children, that's where it becomes a little bit more about pain, chest pain or abdominal pain, belly pain, maybe some vomiting, sometimes that idea of throat clearing because they're trying to pass even their swallowed saliva down their esophagus. They may be picky. They may also have issues with weight gain. Or even some of these food impactions that you referred to can happen in children as well. And young adolescents, young adults, and older adults tend to have what we've described a little bit of the heartburn, the digestion problems. Maybe they're complaining of food going down slowly or having more difficulty swallowing. Those are the things that we hear about. Sometimes also that throat clearing. As we mentioned already, patients who have histories of either personal or a family history of asthma, food allergies, environmental allergies, or even eczema tend to have a high association with this. So we find that if that's part of the history, we always then start to wonder if you're having these type of complaints, should we be thinking about EOE? And it also runs in families. So it's not uncommon for maybe a parent to bring their child in to me because they themselves have EOE and they think their child is maybe having some of these complaints, and vice versa. I get patients who their child has been diagnosed with EOE, and after questioning, they say, hey, I think I might have some of those symptoms. Who should I go to? And clearly, I'm going to say my partner's here in adult GI because we know that this is something that does run in families.
Yeah, it's always interesting whenever you end up taking care of a whole family with this condition, and I wonder what those dinner tables look like. So, we're gonna go to the next topic. How do we evaluate EOE? Dr. Newberry, can you talk to us about what an endoscopy is and why it might be helpful here?
Sure. So I think we've alluded a little bit to this practice of endoscopy during this webinar already, and it's this concept, this procedure where we actually use a camera to look inside the top part of the esophagus and the stomach. And so we are going to do this while you're asleep. The camera itself is thin and flexible, and it's able to see the parts of the body on the inside that we need to evaluate for some of these mucosal changes that you've seen some pictures of. We also can take tiny samples, so biopsies with a device that allows us to take a tiny sample and send it to a laboratory so it can be evaluated under a microscope. Under the microscope, we can look for these allergic changes that are associated with EOE. We can also look for other findings that may be of concern, specific types of infections, changes of the cells that are concerning for precancerous cells and other things we need to watch more closely. And it's important to note, I think this is always a question from our patients, will it hurt to have this procedure? What is this procedure like to actually have? The whole thing really only takes 10 minutes. You're asleep and comfortable during the procedure. The biopsies that we take really don't cause any pain or discomfort. They're very tiny pieces of tissue, and there aren't really nerves in these areas to cause pain or discomfort. And so it's a really simple way for us to get a further evaluation of what's going on the inside.
Yeah, as Dr. Newberry said, whenever we do endoscopy, it's very well tolerated. So, as promised, this is what a normal endoscopy looks like. Any features that we should be looking for here, Dr. Newberry, before we contrast to what is abnormal?
So again, just to orient everybody, we're in our esophagus. So this is our feeding tube between our mouth and our stomach. It's a long tube, and it should have smooth walls. You may remember those pictures we showed at the beginning that had a texture change, that had those vertical lines. You don't see that in these pictures. Additionally, you see clear blood vessels in the picture, and that's normal and healthy esophagus tissue. And that's showing that there's good blood flow to the site, that there's not inflammation. Again, they don't look super red. They don't have texture changes. They don't have any mucosal breakdown where you see like an ulcer or blood or something. And so this is a nice, healthy esophagus. And this is what we want to see when we do an endoscopy.
What about here?
So we have some changes in the esophagus here in these pictures, and these are some of the classic findings in somebody with eosinophilic esophagitis. And I will start in the bottom left-hand corner and go across to show you what we're really looking for. So in the bottom left-hand corner, you see the word edema, which is a fancy medical word for inflammation. And the reason why this looks inflamed is you can see you no longer can see those clear blood vessels, and there is extra fluid in this area being caused by some inflammatory process. And in this case, this is an allergic inflammatory process with EOE. Then, if we go to the next picture forward, we see rings. So those are those circular textural changes that are pretty clear, I think, on this picture. Then on the bottom of the screen, in the middle, you will see something called exudates. And what exudates are this, yeah, that white, filmy, discolored tissue that can indicate where the immune system is having more of a response. So again, this is an allergic inflammation. You will see in the top right corner, the furrows, and we had shown these before. These are those vertical lines. So rather than seeing smoothness of the tissue, you're seeing these vertical lines going down the tube. And then finally, in the bottom right-hand corner, you see the word stricture, and stricture is a medical term for actually seeing narrowing. So you can see all the features in this picture. You have, the rings and the furrows and the exudates, and you see actually that the esophagus itself looks narrowed. And this is where, when this starts to happen, when there's scar tissue related to inflammation, this is where people start having swallowing problems that are pretty significant, where food cannot get down because now the area for it to get down is narrowed.
Great. Thanks so much for that overview of the endoscopic findings of EOE. Just to be clear, most patients aren't going to be having all of these findings on endoscopy, but really the reason that we are trying to get ahead of things getting to this point is because of this stricture picture. Once patients get to that point, it's a lot harder to sort of reverse things. And so that's why it's important to diagnose and treat patients with EOE as early as possible. And so Dr. Solomon, with pediatric gastroenterology, you guys have access to transnasal endoscopy, which can allow you to diagnose and follow your patients with EOE. So talk to us a little bit about that.
Sure. So obviously, as a gastroenterologist, I can do conventional endoscopy as well. But one thing we offer for our pediatric patients is something called transnasal endoscopy. What it is a small flexible tube similar to the one that we use for conventional regular endoscopy. It's much thinner, and our patients are awake, so they're not sedated. What we do is we numb both inside of the nose as well as the back of the throat so the patient is comfortable. And then in our practice, we use actual virtual reality goggles, which you can see in the picture here on your right, that the child is distracted watching a video, a movie, a sports activity, whatever they choose. We allow them to choose to be able to be distracted. And then I pass the flexible catheter in through the nose, go straight into the food pipe, that esophagus, just similarly the way that we do a regular endoscopy, and into the stomach. It allows for obviously a faster recovery. The numbing spray wears off in about 15 minutes. There's really very little prep that you need to do, maybe a 2 to 3 hour fast before you do it, rather than a longer one when you're sedating a patient under anesthesia. They recover pretty quickly. Might be a little bit uncomfortable. You feel a little pressure in the nose or even in the back of the throat, but most people really tolerate it very well. I can take the same biopsies through that tiny little catheter. Remember, these biopsies are tiny. They're smaller than a pen point, smaller than a grain of rice. You really don't feel it. You may feel a little bit of pressure or tug during it, but otherwise it's very well tolerated. And the pediatric patients who have done it have come back. So I obviously treat EOE. So these are patients who may have had a few endoscopies and maybe they've gone and decided, I don't want to be sedated anymore. I don't like how the anesthesia makes me feel. And I'd rather come back and have transnasal endoscopy because they don't have to worry about feeling tired. They can go to their sports events in the evening, or they could take a test in the morning and not feel hungry because they have to fast for a long period of time. So it really opens up another opportunity for our pediatric patients to avoid sedation. And remember, sometimes people can't be sedated for a number of reasons, and their medical history doesn't allow it or makes them higher risk. And this allows us to do that in a safe environment.
Thanks for explaining that. That's a really great alternative for our pediatric patients. So we've evaluated someone and found out that they have this diagnosis of EOE. So how do we go about treating it? Well, classically, there are four treatment options, and we're going to go through them one by one. The first is being an elimination diet. Really, a food elimination diet is what we're talking about here. The next is the proton pump inhibitors. Those are those anti-acid medications our patient was on, like the pantoprazole. Swallowed steroids is the third category. And then the last is biologic injectable medications like dupilumab. So, Alex, maybe you can start us off with our elimination diet here.
Sure. So we do elimination diets that are empiric generally, and that means that we are not doing it based on allergy testing. We're doing it based on what are the most common allergens in the population. Um, the most classic approach to this is called the six food elimination diet, where we remove from a patient's diet the six groups of food that you can see there: wheat, dairy, soy, eggs, peanuts and tree nuts, and fish and shellfish. So that's a lot. It sounds like a lot because it is a lot. Um, and it's certainly not easy. But you work with our patients work closely with us as the GI dietitians to help them understand what they can eat, meal planning. But that is the most classic approach. And then after 6 to 8 weeks of doing this, we do another endoscopy. If we do not see those eosinophils greater than 15 per high power field, then we've established that the patient responded to the diet. And then we go ahead and we do this stepwise reintroduction to try to figure out what food group or groups was causing the eosinophils to begin with. So we reintroduce foods one by one, doing an endoscopy after each reintroduction. So basically, it says there 2 to 4 weeks, but usually I have patients reintroduce a group for 6 to 8 weeks, and then have an endoscopy after that. And we are able to identify trigger foods that way. It is a lengthy process, as you can see.
And then on the other side,
Yeah. So the another approach, and when a patient meets with our GI dietitians, we go through all the different approaches and how we can do it and come up with what works for the patient. But the opposite approach is called a step up. So instead of eliminating all six groups, we eliminate wheat and dairy, which are the two most common allergens in the population. We eliminate them over 6 to 8 weeks. If we still see evidence of EOE on the biopsies, then we step up to the four-food elimination diet, where we eliminate soy and eggs in addition to the meat, the milk, and wheat, because those are the next two most common allergens. If we do not achieve remission of the disease, then we will also eliminate nuts and shellfish at that point for an additional 6 weeks. So with this approach, we potentially could have less endoscopies, because if we figure, if they, get a remission from just eliminating wheat and dairy, and then we only have to reintroduce those two groups, that cuts down the process a bit, but it can end up being just as lengthy as the original original process. And we really personalize this with our patients. For some patients, we just do, if like they really feel like this would be way too difficult, we would just start with a 2 food elimination diet, like just wheat and dairy. And we may not step up if that is enough for them. Or a 4 food elimination diet, which would be the soy, eggs, wheat, and dairy. We've even just eliminated milk, which is or dairy, which is the most common allergen. So we really work with our patients to personalize this and come up with what works best.
Thanks, Alex. Would you say that more and more patients are going the step up route rather than the step down, maybe doing either milk alone or the two food elimination diet? What's been your experience?
Yeah. When I explain all the options, I'm commonly getting feedback to start with less. And I like that myself because it is quite overwhelming to eliminate all six groups, but I do have the occasional patient who has read about it and really wants to go ahead with um, the six food. And they have, very similar the erratic the rates of improvement, like with the six food is about 68 or 70% of patients respond to that. The four food is about 50, high 50s. And the two food is a little bit less than that. But actually like half patients will respond to just a milk elimination. So it's a conversation to have.
Absolutely. I mean, a milk allergy is pretty common, so it's often a very appropriate place for people to start. Alex, you see a lot of people with EOE who come to you wanting to talk about an elimination diet. What do you think are features that you look for when you are trying to assess who's going to be a successful patient with an elimination diet?
Sure. Well, generally, if a patient has, as Dr. Newberry showed the pictures of all the different things we look at on endoscopy, if a patient does have stricturing disease, that would be more difficult to treat with diet, and they may need to move to medication to prevent, the problem swallowing more quickly. Um, it takes a very motivated patient to do any of these elimination diets because we're asking them to stop eating their favorite foods where they're not necessarily having, they're not having like a rash or they're not having a bad reaction. They may just over time feel a little bit of trouble swallowing. So we're now telling them they can't have cheese and they can't have, pizza, bread, all these things. And it's quite, so they have to be motivated to want to do diet and maybe they don't want to do medication. So they'd rather try diet first. Um, and then, they have to be willing to stick around with us because it can be quite a lengthy process. As you saw there, 6 to 8 weeks initially, and then all the different food reintroductions. So, they need to be willing to come back and follow up and get the endoscopies. Um, we also think about where are they getting their food from? Do they have access to some of the more specialty foods that they may need, like the non-dairy, non-nut cheese? Um, and so are they going to be able to buy these things? Do they have access to a kitchen to prepare their own food? Because this is quite difficult to do with relying on takeout, or do they have a job where they're traveling all the time and they are not able to cook their own food? Those are some of the things that I consider when discussing this with a patient. And then also their nutritional status. So if they present very thin and underweight, or having had a recent significant weight loss, then taking away many foods from their diet may not be the best idea.
Yeah, so as Alex mentioned, it is a lot of work to do this, and I really don't think that or recommend my patients try to do it on their own. So I'm very fortunate to work with Alex and the other dietitians. They're a really great addition to our team and have gotten many patients through the elimination diet. That said, I think it's really important to be honest with yourself about what you think you can realistically do. I have had a patient recently who went through this, and at the end of it, he said, I'd really just like to be able to enjoy a beer again. So you're gonna kind of have to be honest with yourself, and it's not exactly for everyone. So with that in mind, we'll keep talking about the other treatments. Can you
Should
talk
I
to us,
jump
Dr.
right
Solomon, about the proton pump inhibitors?
Sure, I can. I just wanted to mention one additional thing on what you were saying, which is sometimes you go down a path where you choose a therapy and it works for a while for you. And then, like you said, you may say it's not worth it for me anymore. And it's so important to understand what we're saying, that it's really a team approach. So really having that conversation with your doctor, your dietitian, whoever else is involved in that care team to really personalize the therapy for you. So proton pump inhibitors, or what we call PPIs, we think about them as medicines that lower acid. So you may have seen them on the shelves or used them in the past. Omeprazole, lansoprazole, esomeprazole, pantoprazole, they all have very similar names. These are the generic names, obviously not the brand names. You may see them as other names as well. So they work, and they work in about 50% of people. So they'll have response to it. So it's an interesting reasoning. There's obviously a couple of reasons why this helps. So first of all, you may say, well, it blocks acid, and you guys already told me that EOE isn't reflux, so then why is it working? So we do know that people who are at higher risk for reflux actually are at higher risk for EOE. And why is that? Because reflux, or the acid that comes up, does lead to some damage in the surface, or what we were calling before the mucosa of the esophagus. So that, and that, if it's injured, that means the barrier is impaired. So the barrier is what we hope is protecting the layers deeper. And if it's a little bit impaired, that means these stimulating factors, so maybe it's the environmental allergen or the food that's going down your esophagus, can actually penetrate through and lead to that inflammation or that inflammatory response. So that in itself can help, because if the wall is then repaired because it's no longer being irritated by the acid, that can actually help limit the exposure to the stimulating factor that we're mentioning. But on the flip side, also, we do know that there's another mechanism that these medications actually treat. They actually treat not only by blocking acid, but they block this inflammatory response that actually stimulates these eosinophils, these white blood cells, from coming into the esophagus. So they work in two ways. The other thing is that sometimes, as we mentioned, your esophagus isn't contracting normally. It's a little bit stiffer because of the inflammation. And when that happens, the natural ways that we clear esophagus, which is swallowing, our saliva goes down, the esophagus contracts, those are also impaired. They're not working as well as they normally would. So then, if the acid is sitting there because it's not being cleared, it can also lead to more damage. So it's a really big, complex way that all of these things actually interact together. Now, the thing is that typically you need to be on twice-a-day dosing with this medication. So being able to commit to taking a medicine every day to twice a day is something also, not just, eliminating in a diet is hard, but also committing to taking a medication every day is sometimes more difficult. In some patients may be more prone to be able to adhere to something like this. So the younger patient whose parent is giving them the medicine, or the older patient who's maybe more motivated to take a medicine. But we have all of that in between area, the people who may forget, maybe too busy, maybe you're in college, maybe you're busy with work, and it might be something that you're not so committed or remember to take at all times. The good news is that in general, most people tolerate it well. The side effect risks are pretty low. Your doctor can kind of discuss some of the things that might be, might lead to some of these low risk side effects. But in general, they're a good drug if you're going to take it.
That's a great point to end on for PPI. All of these treatments are only as good as how often you're actually taking it and adhering to that regimen. She mentioned that taking PPI twice a day is going to heal about 50% of people. The studies show that if you're taking it only once a day, it may only be 20 to 30% of people are getting into remission or control of their EOE. So next, we're going to talk about swallowed steroids. Dr. Newbury, can you talk to us about that?
Sure. So we have discussed a couple of the treatment options, Alex reviewing the dietary eliminations that can be helpful in this disease, Dr. Solomon reviewing the acid suppression therapy, and I'm going to talk a little bit about a medication that actually helps with inflammation. I think many people probably are familiar with steroids for different inflammatory diseases. And the way that we actually deliver this medication for patients with EoE is a little bit different than swallowing a pill where the pill gets absorbed into the bloodstream. We actually give a thick liquid version of this steroid so that it's able to coat the esophagus. It's like a syrupy type solution, and it that is a benefit in that it doesn't have a lot of absorption into the bloodstream. So side effects you often see with classic steroids that you take in pill form, things like weight gain and changes in blood pressure and things. We don't really see that so much with this type of steroid therapy. The way that we dose it is also a twice a day dosing, just like the acid suppression treatment. It works in about 6 in 10 people. It can reduce inflammation with that direct exposure with the gelatinous liquid. And there's some information here on the slide about how we actually administer it. So there are these oral suspension packets that are pre-mixed. Also, there are situations where we have patients mix their own medication, and basically you're going to open up one of these packets or mix your own fluid and then swallow it down, and it'll coat the esophagus. You don't eat or drink anything for 30 minutes so the medication can start taking effect, and then you go about your life again. In terms of side effects, as I mentioned, there aren't a lot of side effects as there are with steroids that you swallow by mouth, but in a small percentage of people, they can develop like a thrush, which is like a common fungal like infection that can happen in the mouth and in the throat, which can be treated with another liquid that we can give you if this does happen to you. And most patients don't develop this side effect, but it's just something to be aware of when you're taking this medication.
Thanks, Dr. Newberry. This is a great medication that works pretty quickly. So I'm using it for patients often when they're having flares or are kind of in a bind and need to get some relief quickly. Next, we're going to talk about an injectable biologic medication. Dr. Solomon, can you talk to us about dupilumab?
Yeah, so dupilumab is, as you mentioned, a biologic agent. So that means it actually blocks sort of this immune pathway, this immune stimulation that we've been talking about, and that thereby decreasing the amount of inflammation. So it doesn't suppress your immune system, it just blocks these two pathways that actually are recruiting these eosinophils. This medication was around before it was approved for EoE, so it was approved prior to this for treatment of really bad eczema or even asthma. And in 2022, it was approved for EoA. The dose is actually for most people, so older children, adults, adolescents, is an injection once a week. For our smaller patients, it's an injection usually every 2 weeks, depending on the weight of the patient. So the dosing is a little bit different for young children. And even though the original studies that looked at it said in their studies maybe 60% of patient responded, we're seeing way higher response rates. So really, I don't think I've actually experienced a failure yet, which is amazing. As it mentioned, real world, maybe 80 to 90% of people have good response, and not only with the inflammation, but also that feeling of that swallowing difficulty gets better. So it's actually reducing some of that scar tissue that's there under the surface. And the most common thing I hear is that patients are, there's pain when they put the injection or a little bit of irritation, which is really limited. It's not an allergic reaction. It's just very local at the site. That's the most common thing we see. We always counsel patients that maybe you can have a little bit of an increase in upper respiratory infections. I have yet to see it, but it's a small, concern. But really, the most common thing is that pain or irritation at the injection site.
Great. Yes, my experience has been pretty similar that patients who make it to dupilumab end up doing really well with it. But again, it's something that may not be right for everyone. And so that's why we're laying out all the options for you tonight. So let's bring it back to our patient. He met with the nutrition team after his endoscopy, and he started omeprazole twice a day because didn't want to change his diet at all, and he did have a little bit of heartburn. So he wanted to kind of treat both the issues with the heartburn and the EOE. And so after he started the medication, the plan was for him to repeat an endoscopy in 10 to 12 weeks. But as with many patients, after they start medication, they feel a lot better. So he felt better after about 2 months on the medication, didn't follow up for the endoscopy, and eventually, after time, he stopped the medication. And now he's returning to our clinic 4 years later because his swallowing is worse again. But during that time, his eczema got a little bit worse as well. And so he went for a repeat endoscopy. And Dr. Newberry, I've for some reason made you our endoscopy expert tonight, but here's another one.
Sure. This patient was feeling better and got lost follow-up. And um, when we went back in with the camera, you can see that there are esophageal changes again that are of concern. And in particular, the narrowing that we're starting to see, those strictures, if you remember from the previous pictures, are starting to form. And this is really indicative of scar tissue. And some of this may not be as reversible as it is when it's just inflammation. And that's why it's so important to continue to come and see us even when you're feeling well, so we can try to limit this from happening.
Absolutely. As you can tell from us spending this evening with you tonight, we really enjoy taking care of patients with this condition. So come back. Um, so next slide. After we see this stricture here, Dr. Newberry talked to us a little bit about how we might go about treating it.
Sure. And, sometimes strictures happen even in people that are taking their medications and following up with us, because that can be part of the disease. And unfortunately, we do have ways to treat these strictures. So we actually can stretch out the narrowed part of the esophagus in with using something like a balloon. And you can see a picture here. That's a balloon that we actually put into the esophagus through the scope, and we blow it up to gently stretch open the stricture that has been developed. Depending on how tight the stricture is and how much we have to stretch it, and if there is some tearing that occurs, there can be some chest discomfort after we do this stretching. But most of the time, this will go away pretty quickly. It can be treated with things like Tylenol, and many patients do very well with this procedure. Additionally, if there is a more scar tissue that's developed and we need to do stretching multiple times, we can do that. And usually we'll do that over a period of time. Every few weeks or so, you would come in for another endoscopy. We would do the stretching until we have it stretched wide enough so that you're not having symptoms anymore. And a lot of that scar tissue has been disrupted with the balloon. And this is particularly effective as well in patients that, again, most people do really well with these medications, but there are a handful of people that still can develop this scar tissue even when they're on medications until we find the right regimen. And so this can be another option for treating those as we go along.
Great. That is a very helpful description of how we might be able to treat you, even if you end up developing this scarring disease. So for this patient, they ended up going for this dilation. They had stretching of their esophagus at that narrowing, and they had improvement in their symptoms. But ultimately, that's really only treating the scarring part of the esophagus. There's still underlying inflammation. And so being on some sort of treatment to limit that inflammation is important. And so because of his worsening eczema, he chose to treat both his EOE and his eczema with dupilumab. His repeat endoscopy showed the inflammation on biopsies was gone, and as we end all of these digest webinars, the patient is happy. And that's eosinophil there on the right. So that's really the end of our webinar. We're going to spend some time going through questions for the last 10 minutes or so. Just a shout out for our next virtual webinar. It's going to be talking about functional upper GI symptoms and how we might approach a sensitive upper GI tract. It's going to be in August with another great group of experts from adult GI and integrative health. So let's go through some questions that came in through the Q&A as well as offline. I can take the first one. It says, I have lymphocytic esophagitis. Are the symptoms the same? So lymphocytic esophagitis is a little bit different than eosinophilic esophagitis. It's a different white blood cell that is infiltrating the esophagus. It can cause similar changes in the lining of the esophagus, especially the rings and strictures. And because of that, it can cause issues with swallowing. We see a lot of patients with this condition, but usually it is a little bit different patient population. It's usually patients who are a little bit older, and it may actually affect women more than men, and it is more rare than eosinophilic esophagitis. The next question I'm going to give to Dr. Newberry. It's a little bit of a controversial one. What is the role of allergy testing in EOE?
Yeah, I think that's a good question and is definitely something we're continuing to study. Right now, the literature doesn't necessarily support allergy testing to guide food elimination diets, but I put a caveat in that it is an option for some patients. There is some new studies that are happening, including from Dr. Ghosh here on this line about maybe we aren't testing for the right things. Maybe rather than just looking at foods themselves, we could look at additives for different types of foods. So I would say that it's not our first approach, and it's one of the reasons why we did not put it here in this webinar. But if you have more questions about this approach, I think speaking with your gastroenterologist, and also we work closely with allergists sometimes to help guide some of these therapy decisions. And a lot of our patients with EOE have other allergic conditions that also need treatment. It is something we should certainly consider in the treatment approach.
Dr. Solomon, just to follow up on what Dr. Newberry said, which I agree with, which is that the new guidelines don't really advocate for using allergy testing. Do you use it at all as a part of your practice? I know that you see a lot of patients with food allergies and sensitivities.
Yeah, so I totally agree. We don't use it to guide our treatment or elimination diets. What we do use it for is, number one, as you mentioned, identifying any other factors, environmental allergens that may also be contributing or triggering the inflammation. We also use it to identify patients who might be at risk for a food-driven antibody reaction. So in a food elimination diet, when you pull those foods out of your diet, if you are susceptible to have a conventional allergic reaction, which is antibody-driven, EOE is not antibody-driven, and that's what these tests look for, antibody-driven reactions. If you take a food out of your diet for a lengthy period of time, usually it's a year or so, and then you're exposed or you reintroduce it in someone who is already susceptible, they may have a larger reaction than they would have ordinarily beforehand. So you may not have actually been classically milk allergic, let's say, but maybe you had a low level of antibody response in your blood. Once you eliminate it, your body doesn't see it. So it's not constantly getting exposed. So all of a sudden, if you reintroduce it after a long period of no exposure, you may actually have a more pronounced reaction. And so for that reason, when we're doing diet elimination, we absolutely want to know what the background is for a conventional allergic response, because we don't want to put our patients at risk, or we want to guide them when they do these things to not just reintroduce on your own, but really have a conversation with your team. So our team does include our allergists because of that reason, that we have this back and forth discussion about how we're doing our treatment plans when we're involving food elimination, and what do we need to know about when we're doing allergy testing.
Great. And Alex, I know you talked to us about sort of an empiric elimination diet, but surely some patients come to you with, some results of some allergy testing that they've obtained from an allergist. How do you approach that? Do you weave that into an elimination diet? Do you do that separate from an empiric elimination diet? How do you navigate that?
I mean, it depends how many there are and the severity of the reactions and if they have symptoms from those foods at all that they're aware of. But sometimes, if they had like maybe one thing that popped up that was fairly high, I might add that to whatever elimination diet we decide to do. If they have multiple, um, and they are symptomatic from them, then maybe we would design an elimination diet around that. Um, so yeah, I guess it would really depend.
Yeah, I think that's a lot of time the conundrum is some of these patients who are very allergic in general may come back with a million things positive on their allergy testing, and then it just becomes really hard to figure out, what might be the potential trigger
Yeah.
and what things are worthwhile actually avoiding. Um, Dr. Solomon. Question coming in, any development for a biologic pill or protocol that's not a shot?
There are a number of biologics that are going through testing now. Different ones have worked, different ones are in clinical trials. Injectables, infusion. I don't think I'm aware of a pill form right now, unless it's in the early stages. But there is a lot of research in this area. There are investigational products that are also looked at. I mean, we mentioned these swallowed budesonide product in the slurry. In Europe, they were looking into a kind of effervescent type of pill where it sort of effervesces as like what we think of as, kind of dissolves and bubbles up, so it kind of stays in your esophagus. So there is a lot of drug development in this area going on. So I think that the world and the treatment plans have really exploded, remembering that this condition has really only been described in like the last 30 years. So the amount of information we have collected in that short period of time is enormous. The fact that we have identified the condition, we have a number of treatment options. I mean, we didn't even have some of these 3 years ago. So it really leads us to the fact that this world is changing. It changes daily, it changes weekly, and we learn new things all of the time. So there likely will be development of different treatment options in the next 5 years.
Yeah, I think that's a great sort of question to end on and a great way to explain this disease. It's a young disease. Our knowledge of it is evolving, but here at Cornell, we're kind of at the cutting edge of this. We are involved in clinical trials and certainly can take care of you in the best way possible. But who knows, maybe at this webinar next year, we'll have some new ways to treat it. So I hope you guys enjoyed this evening and learned something about eosinophilic esophagitis. Please feel free to join us next month when we do our next webinar, okay? Thank you and good night.